I know for the last 3 days when going up, everything is been bombarded the information. Still we are finding it out. But you must keep wondering how we are getting so much of information. Now that's where, and how we are making our practices and how we are practicing political medicine. Probably if you see somewhere, all of us some will say that we are practicing with our experience, no doubt about it. There will be certain other, they say, well, this is the guideline. It's very interesting that when you differ with your resident, they will say, some new guideline came yesterday, they talked about it. So it's all a common thing which we all encounter at all places. And in fact, if you really see, most of the time when the internet era was not there, information technology was not there, the word of the professor used to be the fact. Not anymore. And then you realize over a period of time, it's a two-way traffic, and over a period of time you learn so much from your residents, and the amount which you learn from them, and the way they get, and the way we have tech savvy, and they retrieve the data for you. And then you realize that over a period of time, your information base or your knowledge has declined, probably your clinical skills may not have been, but the information, the amount and volume which is coming up is there. And that is where the challenge is. Are we practicing with our whims and fancies, or we are practicing with the evidence which is there, or are we going to practice with the whims and fancies of the evidence, or we have to take the patient issues in consideration or not? This combination together actually what means is an evidence-based medicine. I don't know how, but I just want to put a question to all the audience which is there. Anybody can say what have they usually meant by evidence-based medicine? Because it has been a relearning for me exercise when I was preparing for this talk. I just want to know, anybody, what they meant, understood by the evidence-based medicine. You see, that is the only part, that's what we used to think about it, but when you start looking at it, it's only a part of it. When you start looking at it, if you see, evidence can be concocted also. It is very important, therefore, when we look into it, when we are doing evidence-based medicine, evidence practice, we need to know what we are looking for, why we are looking for, where we are looking for, how we are looking for, and how can we treat. All these things becomes important, and to be honest, this has been a journey for me to understand also to an extent what evidence-based medicine is, and that's what I'm going to discuss today in next 20 minutes. Now, the definition for this was given by Sackett in 1996, though it has been talked earlier by the Oxford group and subsequently in the Calgary group from the Canada, Ontario. They had talked about, and there have been centers now both for at Oxford as well as at in Mac University as well as in Calgary. Now, what he justified it was that it is a conscientious, explicit and judicious use of current best evidence in making decisions about the care of the individual patient. So what is important? Look at the word conscientious, explicit, judicious. So all these things are very important. It's not that there could be like somebody comes and tells you that we want an intraocular lens implant. And if you are in a government hospital, if somebody is very conscientious, he will say like, we have got a good implant, it will not cost you anything, we can go ahead with it. There could be another person who will be extremely smart. He says, this is in the government and this is in the private. It will, I can't ensure you that this is going to give you a good vision. So obviously this is not a conscientious decision, you are befooling the person. Same sort of thing, we keep on following it. This is a very crude example I have given it, but it is extremely important for us to know it, the conscientious, explicit and judicious component of the current best evidence in making decisions about the care of the individual patient. And important stress is individual patient. You try to individualize the care so that the best possible treatment can be given to the patient. That's one part. Secondly, it means integrating individual clinical expertise with the best available external evidence from systemic research. So the young man said about the systemic research, it nowhere takes away your clinical expertise. What we have been thinking is that we probably are becoming, guidelines come, we write down the notes and write our prescriptions. No, it nowhere takes away your clinical expertise from you. What it is trying to say is use your clinical expertise to best of your ability and add it with the systemic research so that you can give the best possible treatment for that individual in that setting. I hope I am clear. Now, this is what is this is how it is there. You have a clinical expertise, you have a best research evidence, and along with you look at the patient values and preferences. The patient's values and preferences are entirely different in South Asia vis-a-vis from the Western world. So we cannot follow what is being followed in Australia, what is being followed in UK, or what is being followed in America. We need to follow the social customs, social beliefs, the religious beliefs of an individual if we want to practice evidence-based medicine. Therefore, what we are looking at it's a clinical expertise, best research evidence and patient value and preferences. And you start looking at it where you are, where do you stand? In fact, all of us, wittingly or unwittingly, believe in it. The only thing we have not been able to concise or put our thought and whether to make it up, whether is it really evidence-based medicine. In fact, this is what is evidence-based. And this is again, you have a patient concerns, you have a best research evidence, and this is the Venn diagram which you see. This component forms the evidence-based medicine, and that is what we are looking at it. I hope it is clear. Now, what it requires? New skills, no doubt about it. Suppose something has come up, let's say a friend of mine was talking about bronchial artery embolism. We know this is the current level of a practice which we are using at hemoptysis. So you need to acquire new skills. If you don't have, you send it to a person concerned who has these skills. Then you do an efficient literature search because you start looking at it, what are the possible mechanisms by means of which you can stop hemoptysis. This is how you will come up, and then you will look at what suits and the best practice you can do in that patient with the resources available to you. Then you do an evaluation of clinical literature by applying the rules of evidence. My dear friend Manoj Singh have presented the data which is there is a classical example how you retrieve, how you read the data. This is nothing else but this is how you how the available data is looked into and then you put into a practice. He recommended that hypothermia, obviously if you want to use, you use it. Everybody has a protocol because no clear-cut definitions and guidelines have come up. Because the data is still evolving, so you go to the literature, you do a meta-analysis, you look at a systemic meta-analysis, you look at randomized controlled trial, and from there you pick up whether the trials were of a good quality or not, and on the basis of what led to those decisions, and then you try to put them in practice and then see whether it is working or not. It is something like in a science, you put in a hypothesis, you generate certain thing, other people do that thing, and they found out whether the results are the same or not. And one of the classical story which yesterday somebody was telling was in the sciences, people used to say, like chimpanzee, we have 48 chromosomes. When somebody looked at it, relooked at the evidence, and came to know this, we have 46 chromosomes. So that is what it means. So you need to evaluate the literature critically. And what are the steps? It reminds me of the 5 ways which we do in smoking actually. If you really look at it, here what we are looking at is asking, acquiring, appraising, applying, assessing, and auditing. What is important is the first couple of things we do, but always we fail in auditing. And when we talk in terms of an audit in the hospitals, people think probably it is being done to punish them. No. It is being done most of the time with an idea that we need to know what we are practicing, what we are doing, and are we able to use the best of the clinical evidence and our expertise to the benefit of the patient or not. Therefore, auditing is an important component, and I shall be discussing a bit about the rest of the thing. So what you do, you first of all assess the patient. That is, you start with the patient, a clinical problem or a question arises from the care of the patient, because patients always come to you with a problem. They will not come and say, "Ki sahab, I have got a viral hepatitis." No, they will come with, "I have a loss of appetite." They will come to you with that, "I am feeling little malaise, lethargy." And then you examine that there is a jaundice. And then the question starts looking at it. So you assess the patient, you find out there is a problem, and you find out that this patient has a jaundice of a recent onset. Along with the jaundice of a recent onset, this gentleman also is having a fever and a low grade which was not there, and there is a prodrome phase. Then you acquire the evidence, select the appropriate resources, conduct a research. Because we see viral hepatitis is very common, but there could be certain things, you do it, reports come up, enzymes are normal. You would have expected in hepatitis the enzymes to go up. So then you start looking at it, there is a patient who has a fever, who has enzymes which are only mildly elevated, not much, which you would have expected. There is a slight rise in bilirubin. But then you start looking what could be the possible other causes. And this is how you go for a research and you try to acquire an evidence with the history of the question which you have posed, what could be the possible reason and cause for it. Then you go for appraise the evidence, then you look at it, the evidence which has come to you through the literature, through the clinical material, you do it a tooth-comb thing, and then you combine it together and find out whether you found an answer to your question or not. And then you apply, talk with the patient, you get back to the patient, integrate, synthesize, and tell what, that's why you do in investigations. I'm giving you one example of it, and you tell them. Then you do a self-evaluation, you make a certain diagnosis, your resident makes a certain diagnosis, and it turns out to be that the resident was right, you were wrong. So you do a self-evaluation at that point of time, where did I go? And if you really see it, every day you do it. You remember only 2 types of cases, where you have done exceedingly well or where you miss it. When you miss the diagnosis, or you hit tangentially, you always try to find out why did I do so? Where did I go wrong? That is a very pertinent question, and that is what an auditing is. After doing it, this is self-evaluation or audit. Now, whenever you look at a question, this is what we look at it. We look at a patient problem. This is the symptoms in simple language. You look at an intervention. This is a drug or a surgical technique, etc., which you want to do. Comparison, if you do it, whether the comparison, if it is a therapeutic, has it been done with a placebo or standard of care, or you are providing a care. If it's a diagnostic test, you look at the sensitivity, specificity with the test which was originally made of the gold standard, which has been there to confirm the diagnosis. And O is the outcome, that is primary, reduced need for hospitalization, secondary. This is basically for the therapeutics. Same thing can be diagnosed, how a test is done, what has been its specificity, what has been its sensitivity. All these things can be put to different questions to be diagnostic, therapeutics, and treatment arms. It can put across the line to anybody, but this is the basis of a question which you call as anatomy of a question. Now, the well-built question is this: the patient or the problem. I will not give tips for building examples. They are given. I think we have talked about it. We go to the next. Now, what are the types of questions you will have in your clinical practice? One will be for the diagnosis. How to select and interpret a diagnostic test. This is a day-to-day problem. We say now quantiferon gold has come up. We say there is a tubercle skin test, which is better. Now we know from the literature which has come up that quantiferon gold is an excellent test, and it is the one which predicts much more than TST2 activity of disease of the patient who can go to the active tuberculosis. So how have you come to know? Because you followed these cases and found out how many of them developed tuberculosis. So it gave you the assessment of that or functionality of that test. Therapy, you again, how to select treatments to offer patients that do more good than harm and that are worth the efforts and cost of using them. My dear friend asked about drug-eluting stent. We know the evidence says only they are required in 10 to 20% of the things. But you look at in the practice, it is the opposite. So we need to answer these questions, and they all come from the evidence-based medicine. Prognosis, how to estimate the patient is likely clinical outcomes. My dear friends, Manoj talk was an excellent example of this particular part of evidence-based medicine. Harm or etiology, how to identify causes for disease including iatrogenic form. This again, so you can frame the question any way that you want. Now these are the type of the studies which we look at it. This is a pyramid. Bottom of the study is the animals research, from where the IVF and other things, they start the way they started. Then you do a case series or a case reports. Then in the hierarchy of evidence goes the case control studies. Then you have the cohort studies, randomized control trials, systemic reviews, and meta-analysis. So it goes, the order of evidence goes up. It's a pyramid which is there, and if you see it, nowhere you will find the expert evidence. What we are doing is in the clinical medicine, it's the clinical expertise. You add with it, the both things they combine together, and you get the best of the results. Now, best study design for a question. This is a short form because I was given 25 minutes if I remember correctly, because it was 15, 25. So I will take 5 minutes. Right, so I looked at it, I have spent 15 minutes now. So the type of the question is, which is the best type of study which you need to look for? If it's a diagnostic question, always look for a prospective blind comparison to a gold standard. That is what you should do it. On the other hand, if it is a therapeutic, you should look for randomized control trial, as a friend said there, then go for a cohort, then case control and case series in this order of evidence. On the other hand, if you are looking at a harm etiology, again randomized control trials are the ones which are going to tell us. In clinical examination, most important is the prospective blind comparison to gold standard. So there has to be somewhere a gold standard, and cost benefit that we do economic analysis. This is a basic fundamental diagram which we need to follow in our clinical practice when we are evaluating, and we must not say that it has been published in New England Journal of Medicine or Lancet or anywhere and we accept it. No. You need to challenge it. You need to come to your own conclusion by after seeing the tables, which Farhad was saying in this house yesterday. See for yourself what they've said is right or wrong, and then you move next step. But this is how we look at the different studies which are there. Now, but there are certain pain areas when we look at it. This is an interesting slide which I got. 27 kgs of guidelines, 3,000 new papers per day, 1,000 new Medline articles, what the poor doctor should do. He doesn't know what to do. I have the privilege of telling my resident, go and find out. How many will have it? You have to do it yourself. Even if I tell my residents, it is much easier nowadays. When old time our professor used to say, we used to abuse him. We used to say, where have you put it? Because it was difficult to retrieve the literature. Now, Again, every encounter with the patient identifies gaps in our knowledge about the etiology, diagnosis, prognosis, or therapy of their illness, and I hope you will agree with this statement. Recent research reveals that even as seasoned clinicians, we generate about 5 knowledge needs for every inpatient encounter and 2 needs for every 3 outpatient encounters. It means our knowledge at any point of time is inadequate. Every day something else with the science coming up, and we need to be updated with all these things, which looks very easy but not as easy practically. Now this is a slippery slope which has been there, and we know the day we passed out our MD, our theoretical knowledge is the best. And as we pass off, I have the privilege of having a grey hair and a professor, but I am very certain if I sit in a theory exam with my residents, I will fail, they will pass. I have no doubt in my mind. Because this is what most of the time happens. Because then you work in your area of interest and other things. But another interesting story is that it was published in Annals of Internal Medicine in 94% of 62 studies found decreasing competence for at least some tasks with increasing physician age. And this is a hard data, hard fact. And let us accept it. And again, what we are finding is there's too much information and there's not enough time. Before internet, we had a paucity of information. Today, we have excess of information. And we don't know what is right and what is wrong. You can come with any answer for anything. And the statisticians and the jadugars, as I call them jadugars, because they are sitting, they can do data to anything. They can do anything with it. And if you are not aware of it, they can take you for a ride. Therefore, it is very important for this gap is improving. I think there are a couple of more slides. So what we have to go is an evidence-based information resources which we need to retrieve, which we need to know. And there is no escape in today's internet era and in today's IT era that we did not know it. If we don't know it, we are lagging behind in time. And what you look at it, what have the Oxford people have started calling it as push, pull, prompt ways to deal with too much of information. I will explain next couple of slides what does it. What is an ideal resource? The ideal resource is that when you are practicing, your iPhones are very helpful, your STC, your Samsung Galaxies with the applications are extremely helpful. It's not that the companies are coming like that only. No, they know you need it. And what you find is located in the clinical setting. That is why I said they're extremely useful. They should be easy to handle and use. The connection net which is there with them should be fast, reliable. That's why we are looking for the internet as a basic, or the broadband, etc. as a basic infrastructure. It should be a comprehensive full text. And the search engine should be effective and should provide you a primary data right there and then. And I hope most of you will agree with this. If it doesn't fulfill it, you are not very happy. But there is nothing called ideal in this world. So what we look at it. If you see it, this is how pre-EBM there was a passive diffusion. We used to publish it and they will come. That is, the journals will come, we will read and we will decide. Now what has happened now is, early EBM there was pull diffusion. Teach them to read it and they will come. That is what it was there. That's what we practiced. Now in a current EBM, what we called is as a push diffusion. Read it for them and send it to them. That's what we are doing nowadays. And further you will see future EBM is prompt diffusion. That is, read it for them, connect it to their individual patients, prompt them and their patients. In other words, we are involving patients now in the patient care. That is very, very important and we need to understand this. Information in the internet age, what is happening? It is a variant, and it's a very interesting thing which one I found out. Information in the internet age may be constrained by the variant of Malthus law. And what is it? You will see it. The amount of information is going exponentially, but our attention is not. That is important. Along with you will see a wealth of information creates a poverty of attention. There is no doubt about it. Then the low cost of production of poor quality information results in high quality information being drowned out. And lastly, you will see the cost of finding specific information rises as the amount of information increases. And I hope you will agree with it. Now, evidence-based journals, we have started getting up. Initially, when they get an evidence, they do a critical appraisal filters. It means this is like you send your manuscript to an editor. He sees it and says, thank you very much, it's not worth it, throw it around. Same way they have put a filters. People who are doing it, they look at it whether this is good enough or not, the information is there or not. Now, look at it, 60,000 articles per year from 120 journals. This is one of the ones BMJ MacArthur update, which you might be looking at it. And what they do is 3,500 articles per year meet only critical appraisal and content criteria. So from the 60,000 articles which are published, they come down only to 3,500 by putting this critical appraisal filters. That is, this is the information which is required. But again, you must remember one thing, they are giving it to you. Their possibility could be the biases of the people who are involved in it. You must remember that. That is as important. And when you put it, this is again a MacArthur unit research extraction application. When they put it into this thing, they found out they further reduced it to 25 articles per year for clinicians. That means they called it as a noise reduction, and what you ultimately find is 5 to 50 articles per yearly for author of evidence-based clinical topic reviews which you are interested in. So from 30,000, 6,000 articles, you come down to 5 to 50, which you can easily read and read. This is how it is working out. Now, this is how the evolution of information resources for evidence-based decision works in this pyramidal fashion. You have a studies, and the studies which you get it are from the original journal articles. Then you have got a synthesis of these studies, which comes from the systematic reviews. When you do it synopsis, this is an evidence-based journal abstracts which you see it. And when you do it further, the summaries, these are the evidence-based textbooks, or they can, the computerized decision supports will give you this thing. And finally, again, you will see the systems. So if you see, there is a hierarchy which moves up forward from studies, synthesis, synopsis, summaries, and systems. That is very, very important to understand it, what stands. So if you are doing original article, you are at the bottom line. And when you are looking at a computerized decision supports, you are coming at the top. Now, this is about systems. You electronic mechanical medical records with decision support. Summaries, you look at it, clinical evidence. Peer is the one which is of an American journal, American Medical Association. Then up to date is the one which is available with us in India. Dynamite, then the synopsis, you have the journal clubs, EBMs, and so on and so forth. This is how you try to get the studies, you try to get the different various modes of information. Now, if you don't find evidences, where to look at? These are different ones which are there. If you don't find anything, research should be done properly, and these are 3 or 4 websites where you can do it. Now, this is the last slide. If you do it, so if you want to keep it up, what we are going to do is prompt some labs and EMRs with a credible evidence-based pedigree, that is one. But this is what we are going to do it. But if you look at the poll, this is the hierarchy we look at it. Here, this is a peer which is for an American medical journal, BMJ clinical evidence, and that is come up with the McMaster University, which you, if you are prescribed to BMJ, thorax, etc., you get it. And up to date is another one which has come from another group, which again can keep you updated about the topic reviews which are there. And then you have NCBI, PubMed, etc., all come up in these criteria. And then the Medscape best evidence. All these are the ones which are available and which you can use. And the push obviously again goes to the BMJ updates and Medscape best evidence. So this can also prompt some labs and EMRs with the credible evidences. This is the future which we are looking at it. One of them is available is the Zincs. Thank you very much, my dear friends. I hope I have given you some idea regarding where we stand in evidence-based medicine, and probably you will be able to use some of you when you go back to your practice. Thank you very much.